I've been given the daunting task of telling you about the small left ventricle in 20 minutes. I will try to show you the spectrum of hyperplastic left heart syndrome, coarctation of the aorta, aortic stenosis, and to tell you something about the importance of the foramen ofile and the interventions that are possible in these cardiac defects. The small left ventricle is a spectrum of diseases, each with its own special characteristics. On the left, we see a heart with critical aortic stenosis, where the left ventricle is not small but rather dilated, but hypercontractile. In the middle, we see a very clear hyperplastic left ventricle. Actually, the left ventricle is virtually not visible. And on the right, we see a borderline left ventricle, where the left ventricle is long but quite obviously much narrower than the right ventricle. The first case that I'd like to discuss with you is a 35-year-old lady that presented at 12 plus 3 weeks gestation. Her baby was found to have a nuchal translucency of 2.5 millimeters, abnormal ductus venosus flow with a reverse A wave, and tricuspid regurgitation. At that time, it was noted that there was a disproportion of the tricuspid and the mitral valve. The left ventricle appeared smaller and shorter, and the left ventricular outflow tract was difficult to visualize. The right ventricular outflow tract, however, was well seen, and at that stage, an aortic arch was identifiable with prograde flow. Despite that, a diagnosis of hyperplastic left ventricle was made and discussed with the mother, and she was then referred for a fetal echocardiography. This is what we saw at 14 weeks. There was a left to right disproportion. We can see that there is biphasic flow over the mitral valve, but the flow into the ventricles is not the same. There is a much narrower jet crossing the mitral valve compared to the tricuspid valve. We can also see that there's some aliasing across the left ventricular outflow tract. And if we have a look at the sagittal view of the arterial duct and the aorta, we can see that there's prograde flow across this aortic arch. This is what the heart looked like at 19 weeks. We can see that the left ventricle is narrow. We can see that there's some tricuspid regurgitation. And we see also that the left ventricular outflow tract is open. At that stage, we were also able to see that there was a small apical ventricle septal defect, and there was bidirectional flow over this small ventricle septal defect. As such, we saw her again at 27 weeks, and we can see that at 27 weeks, the left to right disproportion is much more evident. We can see a small left atrium, a small mitral valve, a small left ventricle, and a rather dilated and large right atrium and right ventricle. In the middle, we can see the pulmonary venous return from the lung going into the left atrium and passing from left to right through the foramen ofile. What we see on the right side is the 3-vessel and trachea view. We can see the arterial duct uniting with the distal part of the aortic arch. The aortic arch is a little bit narrower possibly, and with a little bit of turbulence in it. The borderline left ventricle is an anxiety-provoking condition for the parents and all the doctors and people involved in the management of the case. We should try to predict if a biventricular outcome is possible. This is more likely if the Z-score of the mitral valve is greater than 1.9 and the tricuspid to mitral valve ratio is less than 1.4, which was the case in our case. If the right ventricular to left ventricular end diastolic dimension is less than 2.1, that is positive. If we see that over time there is an increase in the degree of right to left disproportion, that is a negative predictor. The flow across the foramen ovale, if it is left to right, is a negative predictor. If we see that we have prograde flow in the aortic arch, that is a positive sign, as well as if we have biphasic flow across our mitral valve. Having a large VSD has a negative impact. However, if we have bidirectional flow across that VSD, that is a positive finding. So what did you think happened to this baby? Here is the first postnatal echo. We can see a small left ventricle, a large right ventricle, and right atrium. So we had ventricular disproportion. There was a bicuspid aortic valve. There was an aberrant right subclavian artery, mitral stenosis, aortic stenosis, and a small muscular ventricle septum defect. But this patient did not develop coarctation of the aorta. Here we see the echocardiogram of this baby at 14 days. I've now had more than 12 years of follow-up of this baby, and there has never been a catheter intervention or surgery necessary. This left ventricle remained adequate the whole time, and certainly not what we expect when a diagnosis of hyperplastic left ventricle was made at 12 weeks and 3 days. So you may well ask, can we diagnose hyperplastic left heart syndrome in early fetal echo? Well, we can. If you have a look at the video on the left side, you'll see that the left ventricle is smaller and the left atrium is smaller than the right ventricle and right atrium. In the middle video, we can see that there is left to right shunting across the foramen ovale, and that there appears only to be filling of the right ventricle. We can also see that there is some tricuspid regurgitation. Furthermore, we can see on the right side that we have retrograde flow in our aortic arch here. So a diagnosis of hyperplastic left heart syndrome can be made. Here we have mitral stenosis with aortic atresia. You see there's a small little left ventricle, patent mitral valve, but a very small hyperplastic ascending aorta and arch. It is possible in the setting of mitral atresia or mitral stenosis to have a well-developed aortic arch as is seen in the specimen on the left side. This is because there is an associated ventricular septal defect, and this allows the blood that does not enter the left ventricle via the mitral valve to potentially enter it via the ventricular septal defect, or the aorta has a relationship with the right ventricle, as in double outlet right ventricle. This is the echocardiogram of a baby that we knew had Turner syndrome. And this echo was performed at 29 plus 5 weeks. On the left side, we can see that there is ventricular disproportion. We can see that the right ventricle and right atrium are larger than the left ventricle and left atrium. We can also see on the right side that there is blood flowing from the pulmonary veins through the foramen ovale from left to right. So there is in fact bidirectional shunting across this foramen ovale, one of the signs for coarctation. This is the three-vessel and trachea view. We can see a pulmonary artery that is bigger than the ascending aorta and almost the same size as the vena cava superior, suggesting a small aorta. If we look at the three-vessel and trachea view in the color Doppler, we can see some aliasing in the aortic arch, and we see that there's retrograde flow visible. That is the red that you see there in the aortic arch. If we look at the sagittal cut, we can see a large, well-developed ductal arch, and we see a very small isthmus aortic. And on the color Doppler on the right, you can see a small distal aortic arch. So this distal aortic arch appears to be hyperplastic. Postnatally, the baby was found to have a bicuspid aortic valve, indeed a hyperplastic distal aortic arch, and coarctation of the aorta. This baby required intravenous prostaglandin and neonatal surgery. The detection of coarctation remains difficult prenatally. In the Amsterdam and Leiden area, in the period 2012 to 21, there were 116 cases of coarctation. Of these, 42% were diagnosed prenatally. If we only looked at those with extracardiac anomalies, our detection rate increased to 71%. And if we look at those with arch hyperplasia or VSD, our detection rate was 63%. Looking over the years, we saw no improvement with time. Of those that were undetected, 21% presented with circulatory shock. There was a high incidence of lactic acid and impaired cardiac function pre-surgery in the undetected cases. So beware of the isolated coarctation. Use the three vessel and trachea view and measure the outflow tracts to try to improve our detection of coarctation prenatally. When isolated left to right disproportion of the ventricles is seen prenatally, we consider the possibility of coarctation of the aorta. In these cases, hospital delivery is usually advised and the baby is observed until closure of the arterial duct. This can result in separation of the mother and the baby postnatally. In 2018, we looked at 77 of such cases. In 60%, no coarctation developed. On the right and the left, you will see examples of 2 cases where no coarctation developed. Of these 46 cases, 11 required cardiovascular intervention of medication, of which 6 had clinical pulmonary hypertension. In 19, a congenital heart defect was diagnosed, including total anomalous pulmonary venous drainage and borderline left ventricle. 4 babies were syndromic. So proper monitoring in these cases is indeed warranted, and it is advisable to incorporate the risks of additional morbidity and neonatal complications in the prenatal counseling. We come now to critical aortic stenosis. All 4 videos show critical aortic stenosis. On the left side, we can see a little bit of pericardial effusion. We see a dilated left ventricle and mitral regurgitation. In the middle images, we can see below that there is aliasing across the aortic valve. And in the video on the right, we can see very poor left ventricular function. We see very white ventricular wall of endocardial fibroelastosis and significant mitral regurgitation. In the middle, we see the postmortem specimen of that baby with the poor left ventricular function and endocardial fibroelastosis. Here we see the white lining of the endocardium of the left ventricle, showing us the endocardial fibroelastosis. On the right, we see 2 examples of dysplastic aortic valves. Above with a ventricle septum defect and below a valve that is missing a leaflet. You may think it's strange that in my talk on the small left ventricle, I am talking about aortic stenosis. This is because aortic stenosis can develop into hyperplastic left heart, because at some point, the left ventricle is unable to continue pumping. There is very little to no prograde flow through the left ventricle, and so it stops growing. These are 3 images taken in the progression of one fetus from dilated left ventricle due to aortic stenosis, ending up with hyperplastic left heart. On the left, we see the starting image at 17 weeks, where there was a dilated, poorly contractile left ventricle with echogenic walls consistent with fibroelastosis. At that stage, there was a retrograde flow in the aortic arch, monophasic flow over the mitral valve, and left to right shunting across the foramen nephrile. All warning signs for the imminent development of hyperplastic left heart syndrome. At 20 weeks, we can see that the relative reduction in size of the left ventricle compared to the right ventricle, and at 35 weeks, we can see that that left ventricle has become hyperplastic. So is there anything that we can do in order to prevent critical aortic stenosis developing into hyperplastic left heart syndrome. If we intervene at a critical stage before the left ventricular hyperplasia is developing, we can salvage these left ventricles by opening the aortic valve. This is a case where aortic valvuloplasty was performed in the fetus. We see in the middle video the needle passing into the left ventricle. The image on the right shows us the balloon that has been passed through the aortic valve being inflated. When the fetus has a left ventricle that is obviously too small to support a biventricular correction, and Norwood-Fontan pathway is required. Obstruction of the pulmonary venous return or abnormal pulmonary venous return is a reason not to operate in many centers. We can see in this fetus that there is abnormal flow in the pulmonary veins with turbulence. We can see in the Doppler on the right at the bottom that there is an obstruction of the pulmonary veins, and in the right on the top we see that there is even retrograde flow in the pulmonary veins seen. Another reason for abnormal flow in the pulmonary veins is restriction of your foramen ophalae. And here we have a case where we see quite clearly the disproportion between left and right, and the thicket interatrial septum on the left. In the middle image, we see a very tiny opening in the interatrial septum. These cases are amenable to opening of that septum by placing a stent or lasering the septum. Before that is done, you see a Doppler signal, which is similar to that on the right at the top. The right bottom image is of a restrictive foramen ophalae at post-mortem. Why is it important to do those procedures? When there is a prematurely closed foramen ophalae in the setting of a hyperplastic left ventricle, pulmonary hypertension ensues, making the successful performance of a Fontan operation highly unlikely. In the image on the left top, we see an echo of abnormal lung tissue in a prematurely closed foramen ophalae in the setting associated with pericardial effusion. On the right, we see MRI images showing the pattern of nutmeg lung that is typical. It is caused by the development of lymph angiectasia in the lungs. At the left bottom, we see a post-mortem image of a lung with lymph angiectasia. Additionally, pulmonary vein arterialization occurs, and this leads to the pulmonary hypertension. My take-home messages from this talk are that a small left ventricle is a spectrum determined by the anatomy of the mitral and the aortic valves and the presence or absence of a ventricular septal defect. It is important to differentiate between valvular atresia and stenosis, especially in the young fetus, as an open valve means that there is still the potential for growth. One can diagnose hyperplastic left heart syndrome in the early pregnancy when we have retrograde flow in the aortic arch, left to right shunting over the foramen ophalae in the presence of a small left ventricle. Beware of the open aortic and mitral valves in the young pregnancies. Be aware that the heart disease can progress during pregnancy, so a borderline left ventricle can become hyperplastic, and aortic stenosis can develop into hyperplastic left heart syndrome. So refer early if intervention is thought possible. Coarctation remains difficult. It's important to look for additional markers which I could not deal with in this talk. Important also to evaluate the foramen ophalae and the pulmonary veins, because this is important for counseling and also if a fetal intervention is contemplated. I thank you for your attention.